If you treat vein disease by sclerotherapy, these three questions are critical to your practice, and today I'm going to answer all three with cutting-edge microscopic evidence from research published just a few weeks ago. Why is the clot associated with foam sclerotherapy persistent for months? Why does the clot associated with foam sclerotherapy not lead to DVT? Why is the clot associated with SVT a significant risk factor for DVT and embolism? To answer these questions, we need to talk about the recent publication in Phlebology by Parsi and his team. They used powerful Scanning Electron Microscopy, SEM, to draw a clear line between the Sclerothrombus, the Sclerocoagulum, and a natural superficial venous thrombosis. Let's dive in, and be sure to stay to the end where I share my takeaways from this paper and I tell you about an insightful clinical application from my colleague Dr. Chris Pittman. This paper's objective was clear: to move past vague clinical language and provide a standardized, highly specific set of definitions. Using in vitro models and ex vivo patient samples, Parsi's team mapped the structural architecture of each entity, giving us the evidence we've long needed. Let's start with the Sclerothrombus. This is the desired organized clot formed directly by the sclerosance effect. Microscopically, it's a mesh-like distribution of branched fibrin fibers, red cells, and a high number of microparticles. It's organized and robust, and here is the critical distinction between our two main detergents. Sodium tetradecyl sulfate, STS, creates a sclerothrombus with thicker fibrin strands and more concentrated cellular elements. Think of this as the hearty spaghetti with meatballs. In contrast, polydocanol, POL, creates a structure with slightly thinner, more branched fibers and fewer microparticles. The spaghetti with cheese. Both are successful. They're organized sclerothrombi, but the different structures show the impact of sclerosant choice on the final microscopic result. Now the problem child, the Sclerocoagulum. This is the material we commonly called trapped blood. The study confirms this is not a true thrombus. It's primarily hemolyzed blood and disorganized debris. Look closely under the SEM. You see a disorganized mesh of thin, tortuous fibers and fragments. It's essentially a semi-liquid breakdown product. Parsi's analogy? Noodle soup. It's dispersed, watery, and definitely not the organized structure you intended. Finally, let's look at the true acute superficial venous thrombosis, SVT. SVT is characterized by a linearly oriented, smooth, tightly packed fibrin mesh, the Noodles. It's a propagating clot, often triggered by inflammation. This is the evidence for our first question. The Sclerocoagulum persists for months because of compacted red cells, or polyhedrocytes, that form an impermeable seal. This seal drastically slows down natural fibrinolysis, supporting the clinical rationale for delaying aspiration. My UK colleagues suggest that aspiration at 2 weeks, or sometimes longer, is a good compromise. Now let's put it all together. Let's synthesize this groundbreaking science by answering our three starting questions, linking the microscopic structure to your clinical reality. Why the clot persists. The Sclerocoagulum is composed of densely packed polyhedrocytes that form a barrier, preventing swift fibrinolytic breakdown. Why sclerotherapy is safe. The sclerothrombus is a chemically induced non-propagating clot with a disorganized structure, which structurally prevents it from extending into the deep venous system. Why SVT is risky? The SVT clot is naturally formed, has a highly organized linear fibrin mesh, making it prone to propagation and extension into the deep venous system. Understanding all of this gives us concrete strategies to minimize the problematic sclerocoagulum and maximize successful sclerothrombus. Firstly, optimize the final active concentration. Use the lowest effective concentration of sclerosant to induce the organized sclerothrombus rather than excessively high concentrations that cause instant hemolysis and disorganized debris. Second, ensure adequate compression. Aggressive, targeted compression is crucial to promote vessel wall coaptation and restrict the area for the foam-blood mixture to disperse, in this way promoting the formation of a dense, organized clot. Thirdly, use gentle aspiration puncture for evacuation of the sclerocoagulum. When you aspirate, use a large needle to evacuate the sclerocoagulum at the optimal time, typically 2 to 6 weeks. Let the sclerocoagulum flow out rather than squeezing or sucking. This removes the breakdown product without causing unnecessary trauma that could restart the clotting inflammatory cascade. For me, the key takeaway is this. The new nomenclature is essential. It provides the structural evidence to explain the safety of our procedure versus the risk of spontaneous SVT. This precision leads to better clinical communication and, critically, better patient outcomes. Understand the microscopic difference, whether it's spaghetti with meatballs or spaghetti with cheese. Apply these 3 strategies and you will get much better results. Now, at the beginning, I told you I would share my insights from my colleague Chris Pittman. Chris has shared his clinical evidence that if foam sclerotherapy is repeated frequently to ensure that the endothelium is completely lysed, then the dominant outcome is sclerothrombus with minimal sclerocoagulum. He advises frequent retreatment, and he has virtually eliminated the need for sclerocoagulum aspiration. Additionally, he advises treating superficial vein thrombosis by foam sclerotherapy to lyse the endothelium completely and convert the de novo thrombosis into a much safer sclerothrombus with minimal risk of propagation. Click the links below to read Parsi's full paper and to hear Chris Pittman's takeaway. Now, I hope you found this useful. If you did, please give it a thumbs up and share it. It really does help to get the word out there about this sort of research. And don't forget to subscribe to my channel so you don't miss my next podcast. Thank you for watching.